Well, good afternoon. It's such a pleasure to be here. I was born only a few hundred kilometers away in Sevilla, as you've heard, and it's always wonderful to visit the Iberian Peninsula. So it's really a pleasure to be here and also to participate in this fantastic meeting. So you've heard that I'm a neurosurgeon, and I'm interested in the possibility of using chronic electrical stimulation of memory and cognitive circuits as a possible treatment for Alzheimer's disease. So the general field that I work in is called functional neurosurgery, and really this is a field where we are changing the activity of circuits in the brain, and in our view, there's no difference really from neurology and psychiatry. Both are disorders of the brain. When they affect certain circuits, we call it neurology, like when it affects a motor circuit. When it affects a mood circuit, we call it psychiatry. But the end organ that we're dealing with is the brain. And really, the realization that the signs and symptoms of neurologic and psychiatric disease occur as a consequence of dysfunction in the readout of these circuits in the brain. So the strategy then is to intervene within these circuits to regulate the activity of circuits that are dysfunctional as a consequence of illness, to see if one can modulate these circuits and see if one can improve the output and the consequence, can we improve the clinical features of these disorders. This has been applied mostly in motor circuits in the context of Parkinson's disease, and deep brain stimulation is being used extensively for Parkinson's disease, but the possibility of using deep brain stimulation circuits other than motor circuits and circuits that control your mood, circuits that control attention, circuits that control memory and cognitive function is now coming to the forefront, and this is what I'll speak to you about today. The workhorse will be this instrument here. So these are electrodes that we can place in the brain, and I tell my neurology colleagues that no neuron is safe from the neurosurgeons. We can go absolutely anywhere in the brain or brainstem to apply these electrodes, and we can connect these electrodes to pacemakers, and we can deliver a current to the brain, anywhere in the brain, 24 hours a day, 24/7. And so we just have to decide where to put these electrodes and how much current to deliver to that particular circuit to be able to change the activity of the circuit. Now, for those of you that might not be familiar with this has been used now in 150,000 patients with Parkinson's disease, and I'm going to show you a patient with Parkinson's disease before their operation, off their drug, and then after stimulation, without any drugs at all, but only with stimulation of the subthalamic nucleus. And you'll see how disabled these patients can be with freezing, with inability to initiate gait, with a flexed posture. And this is without drug, of course. And you'll see that with stimulation of the subthalamic nucleus, this patient can move much better, can walk much better. And so really by influencing a small area of the brain, which contains about 400,000 neurons, one is able to go from this akinetic, rigid state with inability to walk to someone who's functioning quite normal and quite being able to go back to work. So you see this is a very powerful technique, and indeed 150,000 patients throughout the world with Parkinson's disease have now been implanted with deep brain stimulation to treat their Parkinson's disease. So with the success of Parkinson's disease treatment then, the possibility of tackling other disorders is now being discovered, and indeed these are all the disorders that are currently in phase 1. And you'll see that people are going to treat all kinds of things. For example, they're going to treat obesity, trying to turn down the appetite in the brain. People are going to treat a traumatic brain injury to wake up people in coma, to activate the reticular activating system. So these are examples. But the thing I want to talk to you about today is the possibility of using deep brain stimulation to treat Alzheimer's disease. So this is the premise. You've heard extensively about the intracellular pathology of neurofibrillary tangles and the extracellular pathology of plaques. These pathological substrates are thought to cause dysfunction of the neurons and synaptic dysfunction. This dysfunction then is transmitted throughout the normal pathways of the brain to interfere with circuits function and network function, and this in turn leads to the signs and symptoms of Alzheimer's disease. One can have primary evidence of this dysfunction if one measures glucose metabolism in the brain using a fluorodeoxy PET glucose scan. You'll see here, for example, this is the normal pattern of glucose utilization in the brain, and the cortical ribbon uses a lot of glucose. As you know, the brain uses 20% of all the glucose in your body. But as you develop Alzheimer's disease, then there are areas of the brain where are essentially shut down, where glucose utilization drops. And these areas of the brain essentially are not working. We feel that they are deafferented. We feel that they're missing their inputs, and this is why they go into a state of hibernation, if you like, a state of being asleep and not using glucose utilization. So what we want to do is we want to modulate these circuits. We want to reintroduce electrical stimulation within these circuits to see if one can restore function to the network, and can this in turn alleviate the signs and symptoms that we see in our patients with Alzheimer's disease. Now, we've chosen, of all the targets possible in the brain, we've chosen one in particular, and we've chosen this one called the fornix. So here's the fornix, and this is a white matter bundle. Here is the postcommissurial fornix, so right below the anterior commissure. And this particular structure measures 4 millimeters across and about 1 centimeter in height. And within this structure, there are 1.2 million axons that are myelinated. They measure between 2 and 6 microns. And the idea then is to place an electrode to drive action potentials in these 1.2 million axons. This is what we want to do. So the electrodes that we use are about 1.3 millimeters in diameter. So we don't want to put the electrode in the fornix, because we all know that if you damage these axons, you cause a memory deficit. So we don't want to put the electrode and impale and destroy the fornix. And so instead, we place the electrode immediately in front of the fornix like this. And the idea here is that you place these electrodes and you turn them on and you deliver current 24 hours a day, 24/7, to then activate these axons and hopefully to modulate the activity of the memory circuit. The circuit that we're going to modulate involves, of course, so we put these pacemakers in, of course, as a source for the electrical stimulation. And the circuit that we're going to stimulate is this one. So here you see the fornix. Here's the mammillary body. Here's the mammillothalamic tract, the anterior nucleus, and here's the cingulate, the entorhinal cortex that you've heard about just before, and the hippocampus, and then back out. So this is called the circuit of Fapez, and this is the circuit that we are going to intervene in our patients with Alzheimer's disease. This is what the electrode looks like in the brain. So you can see the fornix quite clearly, and here you see the artifact from the electrode immediately anterior to the fornix, and this is the position of the electrodes that we see. Now, if you do a 3-view MRI, you'll see that the electrodes go through the ventricles, seen here, the right and left. There's, of course, a right and a left fornix. And here you see the mammillary bodies with the electrodes just in front of the mammillary bodies. And here you see, again, in the sagittal view, the electrode and the fornix here. So the first question is, what does the brain think of all this? What are the areas of the brain that are changed as a consequence of the delivery of electrical stimulation through these electrodes? And for this experiment, what we do is we deliver pulses of electrical stimulation through these electrodes and measure the changes in the power of the EEG throughout the brain using a technique called S-Loretta, or low-resolution EEG tomography. So what we found is that when we deliver a single pulse through the brain, we find a very large change in the EEG some 50 milliseconds later. And if you localize that change, it occurs in the hippocampus. So here, with left stimulation, we see the left hippocampus. With right stimulation, we see the right hippocampus. So we believe that this activation of the hippocampus is as a consequence of backfiring, of retrograde firing of the hippocampal outflow towards the fornix. If we stimulate and now wait 250 milliseconds, you'll see that now you get the entire circuit that gets activated. So now you see the cingulate gyrus and the entorhinal cortex. And so by stimulating at one focal level here, at the level of the fornix, indeed, we see the galloping of the activation from one structure to the next and a transsynaptic flow of activity throughout the entire circuit. So by stimulating focally, we are able to produce an activation along the entire circuit that's involved in memory. I'm going to show you what this looks like in real life. So this is a patient who has Alzheimer's disease, who's had it for 2 years. She's a lady who's 65, and she still takes her normal Alzheimer's medications, but we're going to stimulate her right fornix in the operating room, and she's going to tell us what happens, what she feels when we are stimulating her right fornix. Hopefully the sound will work.
Once again, Lozano starts the electricity flowing into Moira's brain.
The patients are awake, of course.
Moira, we're going to turn this machine on. You tell us if you feel anything, okay?
Okay.
So here she is.
5.
It looks like there's a group of people.
Right. There's some people?
I believe that they're people, but
Okay.
I can't say for sure.
Anybody you recognize?
Well, it's hard to tell.
Hard to tell.
Yeah.
Is this like a new scene, or is it a scene from your past?
Oh, jeepers.
Is it something you've seen before, or is it something brand new?
So she can't tell.
Maybe.
Are you feeling warm on
With a few more volts applied, remarkably, the details of the image get sharper.
We lived in this palatial place in Scotland where
From deep within Moira's brain, a childhood memory surfaces.
we just had all kinds of parkland to run around in
So
and
you
everything.
that just came into your mind now?
When I saw that, because the way that the picture is,
Right.
it's grouped.
Okay.
And I'm pretty sure it's a grouping of my sister and my brother.
This vivid memory flash is a sign that Lozano has hit the spot.
So we get these vivid biographical memories in the majority of the patients that we stimulate the fornix. Usually there's a dose dependency, so if you stimulate at a low level, they get some vague recollection. But as you stimulate at a higher and higher level, the details of the scene become richer and become multimodality in terms of colors and sounds and smells and so on. And this particular memory, this lady was 65, and the memory, I asked her later, she indeed lived in Scotland with her brothers and sisters when she was 8. And I asked her, when's the last time you thought of this scene prior to today when we stimulated you? And she said she had not thought of that scene at all for 57 years. So that scene was buried in her brain somewhere. And by stimulating her right fornix at 5 volts, this scene was unlocked and came out. And so this is an interesting phenomenon that we see in some, but not all, of the patients with Alzheimer's disease, that we're able to unlock these usually autobiographical memories. Usually the memories we see are memories of events that occurred decades before. Nothing that occurred the day before or the week before, but usually years and years before, in this case more than 50 years. I told you that one of the fundamental problems in Alzheimer's disease is that there are areas of the brain that are shut down, that no longer seem to be using glucose, and this can be seen using a fluorodeoxy PET glucose utilization scan. And indeed, this is a scan in 6 patients, our first 6 patients with Alzheimer's disease. And this panel on the top shows you the pattern of glucose utilization in these 6 patients compared to healthy, age-matched patients. And basically, what you see is these areas in blue where the glucose utilization is down in Alzheimer's disease. So these are characteristically, topographically specific areas. The hot spots for this are the temporal lobe and the parietal lobe. So these are areas that are preferentially shut down in Alzheimer's disease. The lights are out in these areas of the brain. The brain is not using glucose in this area. Over the course of time, over a year, you expect this to just worsen. With Alzheimer's disease, there's a progressive loss of glucose utilization. So you expect the glucose utilization deficit to get worse and also to expand geographically so that the blue areas, if you like, would get bigger. So what we wanted to know in these patients that are receiving 24 hours a day of stimulation, what happens to glucose utilization in their brain? And this is what happens after 1 month, and this is what happens after 1 year. And what you see is, to our surprise, that we now see areas of increased glucose utilization compared to baseline. So we see some areas, for example, in the temporal lobe, some areas in the parietal lobe, where the glucose utilization comes up. You see this at a month and less so at a year. So this is very encouraging because it means that indeed the lights are out, but there is someone home, and it is possible to turn the lights back on, to turn these areas of the brain back on. And we find that this is very exciting because if we're able to restore the ability of these brain areas to use glucose, it may mean that their functions that were lost with Alzheimer's may also return. You've heard very elegantly from Professor Damasio that there is very significant brain shrinkage and atrophy, also in a very pinpoint pattern in the brain. And the areas of the brain in Alzheimer's that are hit hardest and hit first are indeed the entorhinal cortex and the hippocampus. And so here you see the progression of atrophy as patients transition from normal to mild cognitive impairment to full-blown Alzheimer's, and you'll see the tremendous loss of volume in the temporal cortex and the entorhinal cortex and in the hippocampus. One can measure the rate of atrophy of the hippocampus, and several studies have done this. Here's about 12 studies that have actually measured this. And it turns out that if you have Alzheimer's disease, the expectation is that your hippocampus will atrophy by anywhere between 3 and 7% per year, but the average is about 5%. So if you have Alzheimer's disease, your hippocampus will shrink by 5% per year. If you are a normal individual without Alzheimer's and over 65, it will shrink by 1% per year. So Alzheimer's is a 5 times accelerated rate of atrophy, if you like, compared to average. So we wanted to know what happens if a neurosurgeon puts electrodes in your fornix and stimulates your circuit that contains the fornix 24 hours a day. What will happen to this rate of atrophy? Will it make it better? Will it make it worse? Again, expecting that after 1 year, we were expecting about a 5% decrease in the volume of the hippocampus. So what we did, of course, was we measured the hippocampus using manual tracing before the surgery and after 1 year of continuous stimulation. And here are the first 6 patients. And indeed, each patient is labeled 1 to 6. And red and green are different observers. And what we found were indeed the majority of the patients, number 2, 3, 5, and 6, they lost hippocampal volume in the order of 3% all the way to 14%. But in 2 patients, there was no hippocampal loss. In fact, in 2 patients, there was hippocampal growth. The hippocampus got bigger. This patient got bigger by 5%, and this patient got bigger by 12%. This is unheard of, that the hippocampus would grow in someone with Alzheimer's disease. It's also the first example that deep brain stimulation not only changes the activity of neural circuits, deep brain stimulation also changes the structure of the human brain. We found that these changes in size of the hippocampus were not restricted to the fornix, but in fact we found that there were circuit-wide changes in size. So we found increases in size of the mammillary bodies and also the fornix. So this is a transsynaptic effect that affects the entire circuit. Does this happen only in humans? It turns out no. It happens that we can also make the hippocampus grow in animals by stimulating these circuits. And so here's an example of stimulating the medial prefrontal cortex in rodents, and what we see is increases in the size of the hippocampus in rodents as well. So it looks like this is a general phenomenon that occurs in animals, in mammals that are stimulated when you stimulate these circuits in the brain. The question is, how is it? How is it that delivering electrical stimulation to the brain makes the brain grow? So the first thing we wanted to know is what were the physiologic consequences of stimulation. And what we're doing here is we're stimulating the fornix at 3 volts for 1 hour and measuring CFOS expression in the hippocampus. And what you see is if you simply put the electrodes in but don't turn on the stimulation, you don't see very little CFOS, but you see a tremendous increase in CFOS expression in the dentate gyrus of the hippocampus and in CA3 and CA1. And this indicates that applying electrode stimulation to the fornix drives activity transsynaptically in the hippocampus. So not only does, so then the issue is, if the brain is growing, what could be the possible contributors to the growth? So could it be that you're making more neurons, more neuropil, more astrocytes, more oligos, more blood vessels, or more water? Which one of these elements is contributing to the expansion of the volume of the hippocampus? So we started to measure these. We stained for collagen after DBS, and what we found is a tremendous increase in the amount of collagen. This collagen is in blood vessels. So what we see is roughly a doubling in the amount of collagen, meaning that there's twice as many blood vessels in the stimulated brain after 1 week of stimulation. You see a tremendous increase in the number of blood vessels. We don't see an increase in the number of astrocytes. We also see an increase in the number of in synaptic density as measured by synaptophysin. So we see more synapses and we see more blood vessels in the brain. We don't see more astrocytes. We also see neuronal sprouting. So these are pyramidal cells in the hippocampus after fornix stimulation. You'll see that the animals that are stimulated have more branches and the branches are longer. And in addition, we see neurogenesis in the hippocampus of these rodents. So this is an animal that is transgenic, that expresses cyan red off a nestin promoter, and we see 3 times more newborn neurons in the animals that receive stimulation for 1 hour than in the animals that do not. So it is clear that DBS is also making neurons sprout and is also making more neurons. What could be the molecular basis of this? Well, one can stimulate the fornix for 1 hour and then measure levels of proteins in the hippocampus. And what we see is that the building blocks for synapses, including GAP43, go up. You see here after 2.5 hours, comes back down to baseline after a day. Synaptophysin goes up, and so does synuclein. And in particular, growth factors go up. So by stimulation, we are driving the expression of BDNF in the temporal lobe, in the hippocampus, VEGF, and GDNF. So we think that what's happening is we're stimulating, and the intrinsic growth factors in the brain are being released. The release of VEGF is likely the reason why the blood vessels are growing. The release of BDNF is likely the reason that the neurons are sprouting and that we're driving neurogenesis. So DBS is another way of focal delivering of intrinsic growth factors in the brain. So our data so far suggests that we're seeing a very large rise in blood vessels, increase in neuropil, and increase in neurons. We think that these are the main factors why we see an expansion of the volume of the hippocampus. We did not see any increase in water content in the hippocampus. So we think that these are the main reasons why we see an expansion of the volume and a reversal of the atrophy in some of the patients that we've seen with Alzheimer's disease. We're also able to stimulate, of course, transgenic animals that overexpress various mutant forms of APP and tau and presenilin, as you see here. These are 2 various varieties of animals. And a couple of things here is that, just like you heard yesterday, that 40 hertz can reduce amyloid plaque deposition. At 130 hertz, we also see a reduction in the amyloid plaque, as seen here. This is in the cortex. We also see reductions in tau and phospho-tau and APP. So you've seen here, so this is the animal, the transgenic animal. Here's with stimulation, you see reduction. Here's phospho-tau with stimulation, you see reduction. Here's APP with stimulation, you see a reduction. Similar patterns are seen in the hippocampus. So this is totally unexpected. How does stimulation give rise to a diminution in tau, phospho-tau, and APP? We don't know. But as we develop markers in humans, we can, of course, test this in humans. We know that these changes have consequences because if we stimulate the animals for 1 hour, we see that not only do we get clearance of these pathological molecules, but we also see improvements in memory. So we can take animals that are normal, we can stimulate the circuit and make them supernormal, enhance their memory, and we can take animals that have memory deficits as a consequence of being transgenic and having these abnormal proteins expressed, and we can normalize their functions at least as measured on these tests. So we are now in a position where we can do some of these DBS work in humans, and we are now measuring the levels of beta protein accumulation with PET ligands, in this case like flutamidol. So we're able to do the PET scans before the patients are operated. We're able to measure how much beta amyloid deposits are in their brain. We're then able to stimulate them for 6 months, a year, and then remeasure to see whether indeed there's a drop in the levels of beta amyloid deposits in their brain. I just want to leave you with one other possible thing that we're looking at. This is the possibility of using ultrasound. So rather than DBS, this is a completely different method where there's ultrasound delivered to the brain. This is non-invasively, does not involve making a hole in the brain, but rather using ultrasound waves through the skull. And if you're a rodent and you have ultrasound, it's been shown that the ultrasound clears plaque. Looks like it might be mediated through a microglial activation mechanism, as we heard about yesterday. So we are now treating patients with Alzheimer's disease with ultrasound. We are measuring the levels of amyloid before and after the ultrasound to see whether that too would be an alternative method to clear the plaque. The way that this works is by opening the blood-brain barrier. So here's the first example of a patient with Alzheimer's where we've opened the blood-brain barrier focally. So we can aim the ultrasound exactly to where we want in the brain. We can then give gadolinium. In this case, we can show that we've opened the blood-brain barrier here focally. And then we can go back and we can measure whether that has an impact on the levels of amyloid. So this is a phase 1 study. We have so far treated 5 patients with this ultrasound to see whether it's safe and whether indeed we can clear the amyloid using ultrasound. So we have both the DBS and the ultrasound as potential therapeutic interventions. So in conclusion then, it is quite clear that one can access memory circuits in the brain and that one can modulate their activity using electrical stimulation. Deep brain stimulation has transsynaptic circuit-wide effects and increased glucose metabolism in brain areas that are affected by Alzheimer's disease. We think that we can reverse the glucose utilization deficit seen in Alzheimer's disease using deep brain stimulation. It's quite clear that we're not just producing a physiologic change, but we're also causing structural changes in the brain, and DBS causes neuroplastic changes in the brain that may underlie that mechanism of action. We think that the generation of trophic factors, the expression of synaptic proteins may be important aspects of this and may suggest that perhaps DBS could also change the natural evolution of the illness. Maybe we could stop or repair some of the circuits that are damaged. And so all these findings, of course, are informing the next design of the next clinical trial, and who knows, maybe one day we will be treating our patients with Alzheimer's disease with deep brain stimulation. So I just want to thank my colleagues, my sources of funding, and I want to thank you for your attention. Thank you very much.